And with this, I would like to welcome our final speaker for today, Professor Seong-Mi Park from the Korea University College of Medicine. She's professor for cardiology and the head of the Rosetta Hall Women's Heart Center in Korea University Anam Hospital. The title of her presentation is Gender and Sex Differences in Cardiovascular Disease from Clinical Data and Open Science.
Thank you for the kind introduction of me. This is my privilege to have a lecture in this Nature Forum, and thank you very much, President of GISTR, Seong-Mi, and Nature, and all of organizers and sponsors. And finally, I'm the last one, and I was very impressive with former researchers, particularly basic researchers. It is very difficult to understand and follow them, but I think bench to bedside delivery someone should do to improve the gender and sex differences and improve healthcare for our patients. As you know, globally, cardiovascular disease, particularly ischemic heart disease, is the #1 cause of death. And this is last month published our Korean statistics. As you see, in Korea, cancer is the #1 cause of death in both men and women. But in detailed view, in women, ischemic heart disease is #1 cause of death in single organ. However, men, still, lung cancer is #1 cause of death. But many people do not know well this fact, and many media says that heart disease is men's disease. So I would like to talk about particularly ischemic heart disease regarding gender and sex differences. Let me talk with this case, female, 60-year-old. She has she visited my clinic for chest pain. She has a history of hypertension. Her blood pressure is 140 and 80 mmHg. So I did a treadmill test for the diagnosis of coronary artery disease as angina. Treadmill test showed ST segment depression in stage 2, means the very early stage. She showed significant coronary artery disease, means the positive study. So we are sure that she has a very severe coronary artery disease or stenosis, and we proceed coronary angiography to expect severe coronary artery stenosis. However, she has no stenosis or obstruction on her coronary angiography. Then what should we do? Many of cardiologists do among these four reassurance. Your coronary angiography, your coronary is okay, and you don't worry about that. Or refer to other department as gastroenterology or psychiatric department, or back to the local clinic for optimal BP control, or I have no idea. But if these patients came to me, I would say her, your test is abnormal, and your heart has something special, so you need a more assessment. This is well-known sex differences of pathophysiology of coronary artery disease. Women likely have a smaller heart because women have a rather than small stature, and with a smaller vessel size. And women have diffuse atherosclerosis rather than focal stenosis. So if we do coronary angiography or coronary angio-CT, we do not recognize luminal narrowing because of diffuse atherosclerosis. And the other is, women has a less fibrotic plaque with more lipid-filled foam cells, and women suffer more plaque erosions compared to plaque rupture in men. So plaque rupture is acute, so we can easily detect, oh, these patients have acute MI or coronary artery disease, acute coronary syndrome. But women has like this erosion, so we might not miss. This is ACES National Data Registry. They show that in clinical practice, female patients has more likely have non-obstructive coronary artery disease. This angiography is for the highly suspected for the coronary artery disease, but female has more likely have non-obstructive coronary artery disease. So at this time, wise studies are published. Then we are eager to have some our own data set for the evaluate the sex differences, chest pain, diagnostic approach, coronary artery status, and treatment. So this is the only nationwide multicenter stable angina registry in Korea, Korean Women's Chest Pain Registry, named KOROS, since 2011. We have a subgroup KOROS studies such as depression survey, Doptam stress echo, KOROS CFR study, and awareness survey is already published. And last month, we just started a Korean registry of high-risk pregnant women, KAINAU KOHIPO. From the KOROS data, we also see that women have more likely to have a non-obstructive CAD compared to men. So, previously, we say angina pectoris, coronary artery stenosis, coronary heart disease. Now we say the ischemic heart disease regardless coronary artery status. So ischemia with non-obstructive coronary artery disease, we say INOCA. INOCA is more prevalent in women. Let's see the microvasculature of coronary artery. This is a cryomicrotome of human. You see the many microscopic vessels are in myocardium. Coronary microvascular circulation covered more than 70% of blood flow of myocardium. So, impairment of coronary microvascular circulation may cause chest pain or dyspnea or kind of MI. But coronary angiography and coronary angiography cannot detect this. We cannot see the microcirculature. Coronary flow result for the assessment of coronary microcirculation is easily conducted in echo lab. And this is what we do, the assessment of coronary artery, coronary microcirculation baseline with adenosine divide. We can easily obtain the CFR. CFR less than 2 or 2.3 means that impaired coronary microcirculation, and who has chest pain and ST depression and low CFR, we may say you have a coronary microvascular dysfunction and may have a microvascular angina. This microvascular dysfunction is more prevalent in women as this, but both men and women, lower CFR shows poor prognosis. Let's see our data. We did coronary microvascular function test, but even the similar CFR prognosis, you see the pattern. The pattern is quite different between the two sexes. Men, CFR is higher, it might be elevated very early stage and maintained, but women Women, as you show the red, very steadily increased. However, the RPP, which means the rate pressure product as for the oxygen demand or consumption, is higher in women. This means that women may have more symptomatic if they have a coronary microvascular dysfunction. So CMD for INUCA is more prevalent in women. So specific assessment with clinical awareness or suspicion is required. As a founding editor-in-chief of International Journal of Heart Failure since 2019, I wish our journal like Nature. Yeah. And as editor-in-chief, I would like to introduce or do practice research with aspect of gender differences. So I invited a review article from Professor Jagrosek. She is founder of the International Society of Gender Medicine and as a cardiologist. And she gave me a beautiful review article as this. Women has a concentric remodeling to pressure and less apoptotic and may have a preserved LVEF, which is prone to heart failure with preserved LVEF. So therefore, women have a little bit smaller heart, and more concentric remodeling with diastolic dysfunction may make a dynamic alveolar obstruction like a fixed aortic stenosis. Then blood cannot go out beyond the aortic valve, so can cause chest pain or dyspnea when she is exercising with tachypnea or versa. I saw the similar finding from the WISE study. I have a chance to study with Noel, and I published this article. Lower CFR, which means the myocardial perfusion reserve index, they have more LV concentric remodeling and worse diastolic function. So women have more concentric remodeling and lower CFR and worse LV diastolic dysfunction may cause a chest symptom rather than men. In heart, we also say that about the estrogen. Estrogen has certain protective effect for the atherosclerosis and vascular dysfunction. Therefore, thanks to the estrogen, cardiovascular disease, particularly coronary artery disease, develops about 10 years later than men in women. As you see, clearly seen the peak elevation of prevalence of heart attack or fetal coronary heart disease is perfectly 10 years gap. So I'd like to see the effect of menopause. This is Anam hospital data of Cardiology data. We see that there is no wonder postmenopausal women have more coronary artery stenosis. This means the epicardial coronary artery stenosis. And I am very interested in the epicardial adipose tissue. Epicardial adipose tissue is very obviated to myocardium and share the coronary artery together and act as a paracrine to excretion of pro-inflammatory or pro-atherosclerotic. You see that many papers say that EAT, adipose tissue, is related to coronary artery stenosis or atherosclerosis. So we saw this. You see that only postmenopausal women has such a relationship, EAT thickness and coronary artery stenosis. We assume that because we did not sample the estrogen level, but we assume that postmenopausal woman, EAT is increased because of depletion of estrogen and decreasing brown adipose tissue. Brown adipose tissue is very favorable effect for the cardiovascular disease. So they may have EAT and coronary artery stenosis were correlated only post-menopausal woman. Besides normal menopause, we would like to see the effect of early menopause. Early menopause is a very women-specific cardiovascular risk factor, particularly in young women. But in clinical practice, cardiologists rarely ask her the menstruation history. Do you have menstruation, or are you in postmenopausal state, or when is your last menstruation? So from the Cardiology data, we saw that abnormal diastolic dysfunction is proceed, and poor clinical outcomes with women with suspected angina. We should do medicine, evidence-based medicine. I like this paper from Nature 2010. Yeah, the picture, you see that there is very few drugs for the women because of gender inequalities in biomedical researches. So this is the percentage of participants in clinical trials supporting FDA. You see that particularly ischemic heart disease, less than 30% of women are enrolled for the clinical trial. This is a recent study, recent meta-analysis with clinical trials, still similar. Still, ischemic heart disease is 22% of women only enrolled. But the adverse drug reaction is too many in women. This is all of the cardiac disease, and they take every day, means the everyday drug, but women do not know which is, or I might have adverse drug effect. So I would say back to the Nature 2010, back to the Back to the Future. Yeah. And in clinical practice, we're trying to figure out or choose the optimal dose for women and to kind of like a puzzling piece of puzzle. And this is for example, a beta blocker. Post hoc analysis biostat heart failure trial and validation coefficient heart failure. You can easily see two graphs. Blue is for man. Blue is for man means that the bottom recommended beta blocker dose percentage. Man, lowest hazard of event occurred at 100% of the recommended dose. There is no wonder because the clinical trial, they recommend with man. But you see the red line, red curve, show that approximately 30% low risk at only 50% of recommended dose. So they say they would recommend female may have a half dose of a beta blocker and other RAS blocker may have enough and similar effect of drugs as men as. So there are unmet needs for the evidences of efficacy and safety in women. So I would want to see whether this concern has been changed or we need more effort to catch up with this gap. So I used the Korean National Health Insurance Service database as open data. This study was a big data research work supported by the Korean Society of Cardiology. We made a definition of AMI very cautiously, and we had two definitions of new AMI. One is for the AMI code and every 1 year washout in admission, and cardiac enzyme lab codes, and the other is coronary angiography. You see that women is elder than men by 10 years, as I said before, and 55% of women are more than 60 years old. And women have more comorbidities such as hypertension, diabetes, and dyslipidemia. This graph shows that the incidence of AMI has increased between 2011 and 2018. Women were less likely to be diagnosed with AMI than men, and this gap has been increasing. This is graphical abstract. You see that women is under-recognized whether women did not go to the hospital even they have AMI or chest pain, or medical staff did not diagnose her as AMI. And women has a less invasive diagnosis such as coronary angiography, still lower than men, but as long as coronary angiography, we have a chance to have a PCI. So PCI rate is increasing in women as men, but still lower. This is for, we can explain that there is no AMI or MI with non-obstructive coronary artery disease, or too late to do something. This is gender differences in prescription. Intensified statin and beta blockers are class 1 indication for the AMI, but women women's are less prescription. And women's are severe clinical condition with ventilator or ECMO, and early and late mortality is higher than men. However, women is elder than men by 10 years, so we adjusted the age, but after adjusted, still, early clinical outcome is poor than men. From this big data, women with AMI has an under-recognized, under-diagnosed, and under-treated 4 years, and more severe clinical outcome and higher in-hospital mortality. Early clinical outcome was worse, but long-term outcome was better among survivors if she is survived. These results suggest that certain efforts to close the gender gap are necessary. And big data can make is helpful to make some medical service strategies. This will be presented next week as a scientific meeting of Korean Society of Cardiology. Regional differences of prevalence by diagnostic criteria of AMI. You can see that the red is the very high prevalence of AMI. 경상북도 and 전라남도 in Korean. And we see how, where, who we do more medical service. You see that, oh, sorry. How can you back to the slides? The last of two. Regional province, women has very less likely to have coronary angiography, even they have diagnosis of AMI, which means that we need to consideration and focusing to the medical service distribution regarding. This is my, let me summarize my talk. There are sex and gender differences in heart disease, and ischemic heart disease is the #1 cause of death in women rather than men. And there are lots of different sex and gender differences in heart disease like lists. However, most of clinical researches have done in men. Therefore, we need clinical trials with aspect of gender and sex greater in women-centric from the beginning stage and with their purpose of heart disease. And medical big data is helpful to assess real-world findings, but we should analyze big data with consideration of sex and gender differences and of already biased in clinical practice. Yeah. Thank you for your attention.
Thank you very much, Professor Park. Do we have any questions from the audience? Yes, there's one over here. Microphone is on its way.
Can I ask questions in English or Korean?
If you want to ask in Korean and maybe we can get a quick translation afterwards, that would also be okay, I guess.
I will ask in English.
Okay.
For your open data research, how can you adjust the gender differences? Because from the previous talk, the gender differences originated from the hormonal status difference. But in the open data like NHIS data, we don't have hormonal status. We just have gender, male or female, and age. So I am wondering how can you make those adjustments?
Yeah, thank you for the very important questions about sex and gender differences in cardiovascular disease. As you see, sex means that more for the biological aspect, and gender is for the social economic background. The first part of my research is for the kind of sex differences, and the big data may show the gender differences as a pattern of use of medical service or the clinical practice by medical staffs. So we need to recognize or awareness for the women's heart disease.
Okay, are there any other questions? Yes, there's one more over here.
Thank you so much for your special effort to increase the awareness of the women-specific. I'm targeting the women-specific for the cardiac disease. And my question is, in your lecture, you mentioned that in women, the size of the heart and the artery thickness, is smaller compared to the men. But my question is really smaller in ratio or still concerning the body weight or height? Mm-hmm. I mean, I thought naturally it could be small and thin, but is it even considering the so what I'm saying is it's relatively really small.
As I understand it, what if we indexed by body surface area, the size or the LV mass is similar between men and women, right? Even indexed body surface by body surface area, women have a small-sized heart, but women more likely to have concentric remodeling. So our diagnostic criteria for the LV hypertrophy is lower in women than men.
Okay, I mean, it's really interesting.
Yeah, very interesting.
Thank you so much.
As I before lecture, I discussed about the LV ejection fraction or function in women. And this is very different from men.
Oh, yeah. Okay. That's really interesting observation. I really wonder what would be the benefit of evolutionary point of view. Why? I'm just wondering. Thank you anyway.
One thing is that women with heart disease are still less treated, diagnosed, but the evidence is also still a few. So this needs we need to have more to do something more
Accessibility.
to overcome.
Yeah. Thank you.
Yeah.
Thank you.
Okay, thank you very much.
Yeah.
Professor Park, let's give her another round of applause.